Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. I'm your host, Patrick Hutzel, founder and director of Intensive Care at Home and IntensiveCareHotline.com. We will be going for up to an hour here today again to answer your questions live on the show. If you have a loved one in intensive care or if you need help with intensive care at home, any questions are welcome here. I also want to welcome our viewers on replay that watch this show on replay. But in the meantime, type your questions into the chat pad or join me live on the StreamYard link. Before we get started, just a little bit of housekeeping. So type your questions into the chat pad, or you can connect with me directly here today on StreamYard. I've posted the StreamYard link in the chat pad. Just click on it and I will let you into the call. Now, what makes me qualified to talk about questions and answers for families in intensive care and intensive care at home? I am a critical care nurse by background, having worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care all around the world since 2013 here at IntensiveCareHotline.com. And we have saved many lives with our consulting and advocacy, and you can verify that on our testimonial section at IntensiveCareHotline.com, and you can verify it on our podcast section at IntensiveCareHotline.com, where we have done some client interviews verifying the work that we've done for them and with them. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are providing a genuine alternative for a long-term stay in intensive care for predominantly long-term ventilated adults and children with tracheostomies, but also for adults and children that are not ventilated, have a tracheostomy, or for adults and children that are on BiPAP, CPAP, and don't have a tracheostomy. We also provide home TPN services, IV potassium, IV magnesium infusions at home, central line management, peak line management, port management, as well as Hickman's line management at home. With Intensive Care at Home, we're currently operating all around Australia, in all major capital cities, as well as regional and rural areas where NDA is approved, TAC in Victoria, ICARE in New South Wales, and NISQ in Queensland, as well as the DVA. You can find more information at Intensive Care at Home. With Intensive Care at Home, we've been operating since 2012 in Australia. Now, today, I want to focus once again on questions for families in intensive care. I want to read out some emails, of course, once again, that we had from readers during the week. One email that stood out this week is an email from a gentleman called Peter, and I'm not going into giving away any identities here, of course. Email from Peter that came in during the week, who says, "Hi, Patrick, I do appreciate all your efforts to educate those of us unfortunate enough to seek your services and all your invaluable advice from years of thoughtful service throughout multiple decades in several countries and also operating as an ICU nurse manager. I had just been of the belief that poor hospital treatment was far less widespread until I suffered a few seizures leading to calls to the ambulance services on 3 occasions over a 6-week period in late 2020. Now, this is a subscriber in Australia. I'm not going into locations or, I'm dealing with an international audience here. We're dealing with clients from the US, Australia, UK, Ireland, all over the world, really. But this is a client who wrote in, who is in Australia. And he continues, having not suffered seizures in the past and not being required to attend the hospital after being checked by ambulance services on the first 2 occasions, I was relieved and just had considered myself worn down after lots of work in my yard during the spring after a COVID shutdown for most of the year. Then came my 3rd seizure, and that is where I went to the emergency department in the ambulance after taking several doses of what I was told was Panadol off more than one ambulance officer, as several ambulances had attended my premises in a short period of time. Upon arrival to the hospital and a short ramping delay of less than 20 minutes, I guess I was ushered into the emergency department of the hospital. I was scanned with a brain scan, to which I believe the operator then wanted to rescan me after being concerned by something and then informed me, "Oh no, I'm mistaken, you are right to go and return to the emergency department reception counter," to which I did. Now, after some sitting in the emergency ward waiting room for information on what to do next, I was informed I was able to leave soon, as they were just waiting on the doctor to sign the forms. So I patiently waited approximately an hour longer and asked how long it might take to get my form signed to leave, as I needed to call my friend for whom I care for to come and pick me up in my car, to which came the reply, it shouldn't be long now, and that I could call him and get him to come in and shouldn't be long now. I happily complied, phoned my friend to say I'm okay, could return home soon, would he come and pick me up soon, as I could get out as soon as my papers were signed. So then, however, from here is where my bad medical story really started for myself. When I was awoken by a member of the hospital neurosurgery team in the wee hours, very early morning, as it was very dark, only to be informed I'm in the ICU department of X hospital. What I was briefly informed is that I had a seizure in emergency and collapsed and stopped breathing and was placed on a respirator and taken to ICU. Did I understand that, to which I responded with a yes, asked what is an induced coma. It was explained to me that for my own benefit, I was being sedated in an induced coma so that the pressure in my head could give me a rest while I was in a serious life-threatening condition in ICU, and I said I understood and nodded agreemently. Now, during my stay in intensive care from the 4th of November 2020 until my discharge on 10th of December 2020, I spent a period of 21 days intubated and on a ventilator, and had been informed of them finding a bottleneck brain aneurysm size 0.9 millimeter front left temporal lobe region requiring surgery. Along with what I was informed of after an excruciating 4 days of neck pain and diarrhea that I may have encephalitis, that I was right in grabbing a nurse to communicate my pain, as I had only had one nurse that had chatted with me in 2 days since fluffing up my pillows, walking away 2 days previously when I first mentioned my very painful neck, which resulted in an investigation by the hospital on myself for assault, for grabbing a staff member and pulling them to my mouth to communicate my pain, to which was found I was right in seeking attention when in pain, yet left unattended in pain for 2 days after initially mentioning it, still being in pain for a total of 4 days. That investigation led to my encephalitis test, and to the best of my knowledge, I was informed I had not received my encephalitis test together along with my meningitis test, mainly due to funding costs of that test and the rare disease encephalitis actually is, and that they then discovered that through the investigation and then administered the test, to which I was informed I had encephalitis and that they were doing tests to determine which type of encephalitis. Following that, I do believe there was a 2-day delay in administering the antibiotics due to the treating doctor not being available, as informed when I was questioned my medical understudy, to my disappointment in hearing this response that I had not been administered antibiotics more quickly. Whilst in discussion one afternoon after my first 24 days, I asked my ultrasound doctor how he had known I had DVT, to which I got a belly chuckle and the response, "Oh, that was easy when I came in here on Tuesday afternoon at 2 to 3 like I do every day." He said, "Well, on the Wednesday, your right arm was the size of your leg, with a 40% blockage all the way down to your wrist from your shoulder, and it was in your jugular vein and in the main artery 4 inches from your heart." To which I asked, how do I get DVT in ICU? DVT stands for deep vein thrombosis, when I'm supposed to be rolled. And he replied, with a belly laugh first, then stated, well, obviously they didn't roll you at all to be like that with a complete blockage of 40%. All the way right down to your arm, to your wrist, so close to your heart and in your jugular vein. So, in summary, I've had a 24-day ICU stay requiring oxygen and fed my food through my right nostril and had both arms with intravenous strips for constant 20-minute observations and blood tests, temperature and oxygen levels with 2 lung puncture tests and at least 1 spinal fluid test, EEGs, NCT and frontal MRI tests, and also developed fluid on the lungs from the oxygen resulting in pneumonia, amongst my other tests, to name but just some of my concerns after being informed of a delayed response to encephalitis and the long-term symptoms of delayed response to encephalitis in conjunction with my brain aneurysm, for which I had neurosurgery in March of 23, after a delay in surgery as I had been informed. I should have had surgery within 4 to 6 months due to the seriousness of my aneurysm. However, when I left hospital, I was of the belief that I would have some form of decent out-of-hospital care and support. However, I have found little to none in the important critical memory recovery process of my illness due to neurosurgery, believing I have not been able to recover past the first 12 months in my critical 5-year recovery window to rewire or learn to rewire the now repairing neurological system of mine due to a number of factors, thus denying me access to the STEPS program for cognitive rehab. So, whilst dealing with the effects that come from the restraint in ICU and trauma resulting in post-traumatic stress disorder, an ABI, which stands for an acquired brain injury, and my TBI, traumatic brain injury, they're not trying to focus on the negative to build my sense of accomplishment through small steps in the face of not being able to seek care from my GP in such matters. As he continually stated, Peter, the only person I'm hearing all of this of is you. That led myself to demanding my critical record summary from my ICU stay due to information privacy, as I had already supplied my discharge summary to my GP upon release. However, I'm still facing difficulties after discovering that in spite of what I had believed was my best efforts, that all my critical medical records had been released to my GP under my regular requests, only to discover that this year that I didn't have my ABI or encephalitis or PTSD records either given to my GP, nor had my neurologist marked them on my critical record summary, let alone any long-term difficulties I now suffer with. So, after much soul searching and trying to understand the difficult process, I have also discovered my hospital prescription and dispensary record recently. I am in the process of identifying through the huge list of my critical record summary reports in order to isolate my tests for the discovery and treatment times of my encephalitis, to then hopefully be submitted to yourself for your professional opinion and advice and release to my GP. Yes, and just to interject here, that's what we do. Part of what we do is medical record reviews for our clients to look for medical negligence, to dig really deep on what's happened in ICU or happening if you have a loved one in the ICU right now. We do medical record reviews in real time. So then Peter continues, however, I first have been slowly trying to just compile and put together enough of the right information relating solely to my circumstances from within my critical record summary, as I have many critical records to review on my file relating to these health concerns. I am currently in the process of having an NDIS application submitted as advised by my neurosurgery team, and I'm also required under the direction of the OHO to meet with the patient liaison office in November, and I'm requested to bring an advocate with me on my behalf, to which I have been informed that I can bring an advocate. So, obviously, 2 things here. I just need to stop the email here. 2 things, Peter. We are also providing NDIS support coordination. So if you need help with the NDIS, you are more than welcome to reaching out to us at intensivecareathome.com, and we can help you with an NDIS intake. And obviously, I can be your advocate as part of your meeting with the hospital. Again, that is part of what I do. So once again, Patrick, I fully appreciate and admire your service to individual healthcare, and if possible, I hopefully look forward to being able to discuss and work with you on compiling what critical records and results might help, highlighting such conditions in my critical record summary in order for me to find and relocate those reports in my oversized critical record summary and in my hospital dispensary records, and in conjunction with those of the Queensland ambulance, to then be presented along with my neurology report that indicated they suspect I presented to ICU with encephalitis, thus leading to the nerve and muscle damage I also have now. In closing, I would welcome to discuss which results I need to find my diagnosis and treatment records times in order for me to submit a medical review with yourself, so I can then seek a valid advocate to help me to protect my future healthcare and entitlements after years of neglectful ABI and PTSD treatment, as I have found these past 4 years extremely challenging, and I would truly appreciate your time and professional assistance in seeking your services in the near future. Of course, Peter, you know where I am. I've already responded to your email, and I look forward to hearing more from you and how we can help you, because I know we can help you. Now, but here's an interesting part of this email. I argue not many hospitals get these emails, or if they do, they probably try to brush them under the carpet. What I think we created here at intensivecarehotline.com, but also with Intensive Care at Home, I think we have created a safe space for families in intensive care to share their stories, right? And feeling heard and feeling understood. Because, most hospitals are brushing patients off and say, it's a one-size-fits-all, here's what we do and here's how we do it. And it's a one-size-fits-all without much consideration of the patient and the family and their feelings and how they think and how they feel about their hospital stay, right? And I think any health professional in a hospital, but especially ICU, should listen to what our patients and families have to say, because that's how we can learn, right? It's often through those humble experiences how we learn. So, in closing this, if you have any questions, please type them into the chat pad or join me live on the StreamYard link here. Now, before we go down to the next topic that I want to talk about, we get so many inquiries from families all over the world that have loved ones in ICU. And they say, ICU wants to discharge me. They want to discharge me to rehabilitation. They want to discharge my family member to rehabilitation. They want to discharge my family member to LTAC, especially for our clients in the US, right? They want to send my family member to LTAC, right? And it never ends well. It never ends well when patients get sent to LTAC from ICU, especially in the US. It never ends well. Patients are being discharged too early from ICU. Never ends well. Okay, so today I want to set the record straight, because I keep telling, or we at intensivecarehotline.com, we tell families you don't have to go anywhere. You don't have to go to LTAC if you don't want to. You don't have to give consent, right? But families are so intimidated by intensive care teams, they're giving into the perceived authority of those ICU teams, and they need to stop doing that. And once again, today I want to set the record straight. So what do I mean by that? So we are referencing an article as part of our advocacy. We are referencing an article from a website, Cornell Law School, and the website is law.cornell.edu. And I will post the link there in a minute in StreamYard so that you can verify what I'm saying is accurate. And today I actually want to read out the article on the website. This is obviously for our US base, for our US clients, right? But I want to read out the article today, which is law-based, right? It's from a very credible website. Let me read this out. Paragraph 482.43, conditions of participation, discharge planning. The hospital must have an effective discharge planning process that focuses on the patient's goals and treatment preferences and includes the patient and his/her caregiver support persons as active partners in the discharge planning for post-discharge care. The discharge planning process and the discharge plan must be consistent with the patient's goals for care and his or her treatment preferences, ensuring an effective transition of the patient from hospital to post-discharge care and reduce the factors leading to preventable hospital readmissions. Reduce the factors leading to preventable hospital readmissions. in the number of patients that have gone from ICU to LTAC, bouncing back into ICU in no time. It's ridiculous, right? So it sounds to me like everyone and their dog has considered that discharging a patient needs to happen at the right time and also to the right place, but the hospitals themselves. So then the article continues. Standard discharge planning process. The hospital's discharge planning process must identify at an early stage of hospitalization those patients who are likely to suffer adverse health consequences upon discharge in the absence of adequate discharge planning, and must provide a discharge planning evaluation for those patients so identified, as well as for other patients upon the request of the patient's representative or patient's physician. Nobody could be more vulnerable at a hospital discharge than an ICU patient, because that's what this paragraph is referring to, right? They are extremely vulnerable, right? Then it continues. Any discharge planning evaluation must be made on a timely basis to ensure that appropriate arrangements for post-hospital care will be made before discharge and to avoid unnecessary delays in discharge. Number 2, a discharge planning evaluation must include an evaluation of a patient's likely need for appropriate post-hospital services, including but not limited to hospice care services, post-hospital extended care services, home health services, and non-health services, and community-based care providers, and must also include a determination of the availability of the appropriate services as well as of the patient's access to those services. The discharge planning evaluation must be included in the patient's medical records for use in establishing an appropriate discharge plan, and the results of the evaluation must be discussed with the patient or the patient's representative. Next, upon the request of a patient's physician, the hospital must arrange for the development and initial implementation of a discharge plan for the patient. Any discharge planning evaluation or discharge plan required under this paragraph must be developed by or under the supervision of a registered nurse, social worker, or other appropriately qualified personnel. Next, the hospital's discharge planning process must require regular re-evaluation of the patient's condition to identify changes that require modification of the discharge plan. The discharge plan must be updated as needed to reflect these changes. Next, the hospital must access its discharge planning process on a regular basis. The assessment must include ongoing periodic review of a representative sample of discharge plans, including those patients who were readmitted within 30 days of previous admission, to ensure that the plans are responsive to patient post-discharge needs. You know, sending someone from ICU to LTAC certainly doesn't include evaluating that, because otherwise this dangerous practice would have stopped by now. Then the article continues. The hospital must assist patients, their families, or the patient's representative in selecting a post-acute care provider by using and sharing data that includes, but is not limited to, HHA, SNF, IRF, or LTAC, data on quality measures and data on resource use measures. Well, this is very important, because look up the reviews for LTACs or for SNFs online. They're absolutely shocking, right? So where are the quality measures from the hospital's perspective when they send someone to LTACs? Or is it just friends referring to friends? Next, standard. Discharge of the patient and provision and transmission of the patient's necessary medical information. The hospital must discharge the patient and also transfer or refer the patient where applicable, along with all necessary medical information pertaining to the patient's current course of illness and treatment, post-discharge goals of care, and treatment preferences at the time of discharge, to the appropriate post-acute care service providers and suppliers, facilities, agencies, and other outpatient service providers, and practitioners responsible for the patient's follow-up or ancillary care. Next, standard. Requirements related to post-acute care services. For those patients discharged home and referred for HHA services, or for those patients transferred to a skilled nursing facility, for post-hospital extended care services, or transferred to an IRF, or LTAC for specialized hospital services, the following requirements apply in addition to those set out in paragraphs A and B of this section. Number 1, the hospital must include in the discharge plan a list of HHAs, SNFs, IRFs, or LTACs that are available to the patient that are participating in the Medicare program and that serve the geographical area as defined by the HHA in which the patient resides, or in the case of a SNF, IRF, or LTAC, in the geographic area requested by the patient. HHAs must request to be listed by the hospitals if available. Now, how many times have I seen over the years that hospitals want to send patients to LTAC hours away, often in a different state? That screams insanity, right? A patient, when they're critically ill, needs to stay in ICU to be weaned off of the ventilator, not being sent to an LTAC, right? So far, this all makes sense, but it goes contrary to what the hospitals are actually doing, right? In Florida, for example, I've seen many clients over the years where they want to send them to Georgia, to another state, to an LTAC or a skilled nursing facility. It beggars belief, that someone would do that. Okay, let's carry on. This list must only be presented to patients for whom home healthcare, post-hospital extended care services, SNF, IRF, or LTAC services are indicated and appropriate as determined by the discharge planning evaluation. For patients enrolled in managed care organizations, the hospital must make the patient aware of the need to verify with their managed care organization which practitioners, providers, or certified suppliers are in the managed care organization's network. If the hospital has information on which practitioners, providers, or certified suppliers are in the network of the patient's managed care organization, it must share this with the patient or the patient's representative. Again, common sense. The hospital must document in the patient's medical records that the list was presented to the patient or the patient's representative. The hospital, as part of the discharge planning process, must inform the patient or the patient's representative of their freedom to choose among participating Medicare providers and suppliers of post-discharge services, and must, when possible, respect the patient's or the patient's representative's goals of care and treatment preferences, as well as other preferences they express. The hospital must not specify or otherwise limit the qualified providers or suppliers that are available to the patient. Again, common sense, but not what we see in reality. The discharge plan must identify any HHA or SNF to which the patient is referred, in which the hospital has a disclosable financial interest as specified by the secretary, and any HHA or SNF that has a disclosable financial interest in a hospital under Medicare. Financial interests that are disclosable under Medicare are determined in accordance with the provision of Part 420, Subpart C of this chapter. Very interesting article, and confirms pretty much everything that we've been saying for many years, that a hospital can't just discharge you because they feel like it. There are many steps they need to take, including getting your consent. Also something that I've been saying for many years, and also something that we've successfully implemented when patients are being discharged without their consent, or trying to be forced to be discharged without their consent. Every time clients challenge that, they're not being discharged. Every time, right? But you need to put your foot down. If the hospital say jump, you can't just ask how high. Where do we end up if you ask them, if they say jump and you ask how high? So I hope helps you again to get the record straight now. But also, what I will do is I will actually put a link. Oh, I think I might have been on mute. I'm sorry, I might have been on mute. Might have been talking away on mute. So here's the link to the article. Like I said, I put my money where my mouth is. Link to the article. Now, What else do we have today? I also want to read out some letters again that we have written to hospital executive on behalf of our clients or with our clients to get results, i.e., getting the right treatment for the clients, i.e., making sure clients are not getting discharged any earlier than they should be, just from a safety perspective. So let's get to that. Let's get to that in a minute. But if you have any questions in the meantime, before I get to that, please type them into the chat pad or join me live on the StreamYard link here, right? Either or. You're welcome to talk to me and share your questions. If not, there's plenty of questions that I had come in during the week, but let me just get to them. Now, first letter that we've had for one of our clients that really got us a good result. Just give me 1 second, please. So this is one letter that we've written to hospital executive on behalf of our client, and that got us a really good result, really good outcome. So, dear hospital executive, I'm writing to you in regards to my mother. I'm not mentioning any names here, of course. She has been an inpatient in your ICU since the 31st of October last year. This is obviously a letter from last year. Unfortunately, the care and treatment that she and we as a family have been receiving has not been up to our expectations. Here are the reasons why. We have approached the intensive care team multiple times to get information about my mother's condition. Many times we were doing so, we seemed to get brushed off by not getting all the information. Also, direct answers to our direct questions were avoided, which was made worse by us not having access to the full medical records online. Initially, we were unable to see the medical and progress notes of the portal. Once we were given access to the notes, which took a few days to happen, there was still a 5-day delay to get the latest results online, as well as the updated list of medications. So once again, what's at stake here? If you request access to the medical records, they should be getting that to you within 24 hours, within less than 24 hours. So number one, most hospitals should have all medical records online nowadays. They should have them on an app. They should send you a link to an app or send you a link to a website with a username and a password. And that should be it. It's 2024. There should be no issue with you getting access to the medical records whatsoever. So, and here is another example. Have a think about this. So let's just say your loved one is in hospital and, you would take the hospital to court. I can assure you that if the court asked the hospital for access to medical records, they would have the access to medical records within a few hours. So we all know it's possible, right? We all know it's possible. Okay, so the letter continues, or email, I should say. Last week, we were on a phone call with the doctors and they showed a great deal of resistance in answering our questions. We were wondering what the intensive care team has to hide regarding the treatment of our mother. This negative impression peaked the day after we had another meeting with the doctors and we were told that my mother had brainstem damage. When asked how the brainstem damage was diagnosed, we were told that a neurologist did a physical exam. When looking further into how brainstem damage is diagnosed, it clearly says that brainstem damage is diagnosed with an MRI scan of the brain or a CT scan of the brain. I do vividly remember this when we were talking to the doctors at the time. He was saying he did a physical exam. There's no way you can diagnose a brainstem damage with a physical exam. So, and this is why it's important why you need a second opinion. Imagine the family here would have just given in to whatever the hospital said, that they've diagnosed brainstem damage by a physical exam. I mean, that's where my area of expertise is coming in. I said straight away, well, that can't be right. Right? That's why you need a second opinion right from the get-go. If you don't get that, you'll be fighting an uphill battle. Right? So then we continue. When asked why an MRI scan of the brain or a CT scan of the brain hadn't been done, considering that the neurologist was concerned about brainstem damage, we were brushed off and we were told that a CT scan of the brain or an MRI scan of the brain is not necessary to diagnose brainstem damage. Needless to say, such an approach is completely unacceptable and not up to our expectations. Furthermore, a few days later, my mother had the tracheostomy and was taken off sedation. Since then, she has been waking up, making eye contact, and obeying simple commands such as squeezing hands, wiggling toes, etc. There's no sign of brainstem damage whatsoever. This obviously concerns us in terms of the accuracy of the clinical judgment of the intensive care team and the neurologist. Now you can see why having that second opinion is so critically important. So critically important, right? If you're flying blind, or if you're trying to fly blind, you'll be in for a rude awakening. So then the email continues. Also, there were issues with the MRI in general. We were first told that they were not aware of why my mother was unresponsive and that an MRI was needed. Later, they declined to do it. I asked the attending doctor at the time why not, and he refused to give a reason. When I asked the same attending doctor about speaking to a neurologist, he brushed that off, saying neither the MRI nor speaking to a neurologist was necessary. During a family meeting on the 14th of November 23, an MRI was agreed to. The next day, I was called and informed by a resident doctor that an MRI was not going to be done. When I asked why the MRI was not being done, the resident didn't have an answer. I asked her to find out why, but she never got back to me. I also asked the social worker about the reason for the MRI not being done. Social worker told me she would get back to me, but she never did. Now, I'm being told that the MRI is possible with medical coordination, but it would take some time. At this point, we have now waited 24 days and have not been able to get our mother to have the critical exam performed. We have yet to be given a proper diagnosis of our mother's condition. Now, I can tell you an MRI, you can do that within a few hours in a good ICU with the right setup, with the right skills, with the right mindset. Waiting 24 days is ridiculous. The email continues. With all these negative experiences, at this point, we were adamant about sending my mother out to another hospital at the earliest convenience, and we would like to ask your assistance in doing so. We ask for nothing more than to respect and honor our request in helping us with the transfer of our mother to another ICU that can facilitate her needs adequately and as soon as possible. Furthermore, with the delays in getting access to all medical records and the intensive care team pushing us to give consent to a PEG tube, we feel like we're not in a position to make informed decisions as the medical records online are not up to date. At this juncture, we believe that if the PEG is an option, it should be done after the transfer. So, can you see how ridiculous it is to ask families for, giving consent for certain procedures without having access to the medical records? That is not appropriate, and it is absolutely ridiculous. Now, the email continues. Lastly, given that my mother has now had a tracheostomy, we want to see her being mobilized on a day-by-day basis, having physiotherapy so that she can be weaned off the ventilator as quickly as possible, as we have seen. This necessity from our research, it's clearly showing that nobody can be weaned off the ventilator successfully if they're not being mobilized on a day-by-day basis, and having physical therapy and breathing exercises on a day-by-day basis. We are requesting this to be implemented tomorrow. So that is a lengthy email that we have crafted together with our client, and that really got us a good result. Their attitude changed, their approach to treatment changed, and unfortunately, that's what you have to do. Unfortunately, it's very sad that, it takes writing emails and letters to get hospitals going, right? It's very sad. So, now, then there's a follow-up email from this. Things had improved, but then they were getting worse again. So let's go through the next letter that we sent, or next email that we sent. Dear hospital CEO, I'm writing to you regarding my mother. She has been an inpatient in your ICU since the 31st of October 2023. Unfortunately, the care and treatment that she and we as a family have been receiving has not been up to our expectations. This is in light of the fact that I've written to you before and many issues remain unresolved. Whilst our mother has significantly improved, the reality is that if it hadn't been for our advocacy, she potentially would have passed away by now, because the intensive care team has been pretty adamant from the start that she should be having comfort care only, that she wouldn't have any quote-unquote quality of life if she was to survive. The reality is she has survived so far, and we believe that with ongoing good care and treatment, she will improve her quality of life. However, we are very concerned that in this hospital she's not getting the right care and treatment. Here is why. Let me explain. First off, while she was in ICU, there have been delays in her MRI scan initially, and she was left undiagnosed while she wasn't waking up. To make matters worse, we were told that my mother has had brain stem damage, even though a neurologist had only done one physical exam. Our research has clearly shown that brain stem damage can only be diagnosed with an MRI scan of the brain, CT scan of the brain with an EEG, or a combination of all of the above. Clearly, we as a family have been misled. That could have led to the death of our mother because of the way her diagnosis has been positioned without providing any evidence. And I'll put a link towards how brain stem damage is being diagnosed. We feel very much disrespected and judged by our wish to continue careful treatment for our mother, even though the intensive care team has been pushing for comfort care and hospice, which in essence would have killed our mother if we had given in. Furthermore, the constant inappropriate push and bullying from the intensive care team for a PEC tube and our decision not to proceed has been a nuisance, to say the least. We have done our research and our mother is perfectly safe with a nasogastric tube and not having a PEC tube. We feel like the push for a PEC tube from the hospital is only to send our mother to an LTAC facility, which we simply don't want. Our research has shown that patient outcomes in LTACs are not up to our expectations. Therefore, we do believe that this hospital needs to take responsibility to help our mother to get best care and treatment and therefore best outcomes. However, we have ongoing concerns that with my mother moving to another area out of the step-down ICU, the hospital continues to be negligent and doesn't have my mother's best interest at heart. Here is why in all this time since the 31st of October, my mother has not been mobilized in getting out of bed. There should be absolutely no reason why my mother can't get out of bed with the help of the doctors, nurses, and physical therapists. As she has no fractures, she's hemodynamically stable. Therefore, she should be getting mobilized every day. By not mobilizing her, she's getting deconditioned and weaker every day. I can tell you from all my experience, mobilizing patients is absolutely critical. You need to do that as soon as you can. And if you do that, you will actually see patients improving, assuming they're hemodynamically stable, they're not on inotropes, they're not on vasopressors, they don't have any fractures that contraindicate that patients can get mobilized. And if hospitals are not doing it, they're absolutely negligent. Absolutely negligent. So the email continues. Many studies in hospitals have shown that not mobilizing patients leads to complications that could lead to serious injuries or death. Other risks by not mobilizing her is that she will end up with contractions of her joints and that she'll end up with pressure sores. Should she end up with contractions or pressure sores because the hospital chooses not to mobilize her, we will deem that as medical negligence and we will reserve our right to consult our legal team about any medical negligence. Lastly, yesterday my mother had the tracheostomy dislodged and it looks like a medical emergency was called. Now, my concern is that she was prematurely discharged from ICU into another area where the hospitals may not have the skills and expertise to look after a tracheostomy. When tracheostomy patients leave intensive care, not all nursing staff in other areas are tracheostomy competent, and we are concerned that might be the case in this situation. And look, I've been preaching this for many years, that a tracheostomy needs to be looked after by intensive care nurses only, right? There's really no other area in a hospital beside anesthetics, where hospital staff, doctors, nurses can safely look after a tracheostomy, right? It needs to happen with ICU nursing staff. And I am so not surprised that the tracheostomy got dislodged. I am so not surprised. And you can look up the mechanical home ventilation guidelines, by the way. So with intensive care at home, we're providing evidence-based nursing care at home. And with evidence-based nursing care, you will see that with our mechanical home ventilation guidelines on our website, it says that only critical care nurses with a minimum of 2 years critical care nursing experience, ideally with a postgraduate critical care nursing qualification, can safely look after tracheostomy and ventilated clients. That's in the community, but that also includes hospitals. You know, if you're sending tracheostomy clients or patients to a ward with ward nurses, there are no tracheostomy skills. Okay, so then here we carry on. Moreover, we have asked for a meeting with the medical director, and we are not allowed to have an advocate over the phone. Once again, what is that the hospital has to hide by bringing in an advocate? What is it that an advocate can't hear or see? We're also getting tired of vague answers to our very direct questions. Once again, the hospital seems to have things to hide. Last but not least, we still expect the hospital to help us transferring our mother to another hospital, the hospital of our choice. And we expect this to happen in the next few days by the hospital reaching out to other hospitals to help us getting our mother to a hospital of our choice. We have also picked up that our mother is getting Ativan. Given that Ativan is sedation and a tranquilizer, and given that she's not fully alert, we also would like to have the Ativan, which is also a benzodiazepine, by the way, stop. So our mother can have every chance to wake up as best as she can without any tranquilizers or benzodiazepines going into her system. That's how the email concludes. Well, that is another thing that we see, and I've seen certainly working in hospitals, you know, to keep patients sedated unnecessarily. And nobody should be keeping patients sedated unnecessarily because they're perceived to be a quote-unquote pain. And in this situation, the family was, you know, feeling to be pushed towards end of life anyway, right? Which is ridiculous. No one should be pushed towards end of life. No one, if they don't want to. Okay, so next, another letter that was sent to hospital executive is, oh, hang on, no, this is not actually. Just give me a second. No, that is not the one. Yes, here it is. So, letter to hospital executive that we helped write with one of our other clients. So, dear hospital executive, my brother has been an inpatient in your ICU since the 10th of January 2024. We have been asking for access to my brother's medical records as my father and I are the current healthcare proxies for my brother. So far, our requests have been ignored, and that's very concerning in light of the fact that the first clinical judgment from the ICU team was grossly incorrect. The ICU team thought my brother was, and he puts in quotes, brain dead, which turned out to be gross misjudgment, and thankfully the brain death tests turned out to be negative. But that's what hospitals often do. They start using the word brain death without having the evidence to create a narrative that is very negative, right? And if you don't know the terminology in hospitals, if you don't know how ICUs operate, if you don't know, you know, what goals ICUs often have, you might believe the narrative. And if you believe the narrative, your loved one might die unnecessarily because you're giving in to end-of-life care and so forth. So let's continue with the email. We should have had access to the medical records right from the start so that we could have shared those medical records with other third independent parties who can provide a second opinion in such dire life or death situations. Obviously, under Missouri law, this was a client in Missouri, we have the right to access the medical records at any time we choose to, especially in light of the fact that the ICU team has asked us to give consent to medical treatment such as a tracheostomy, etc. In order to make informed decision, we need this access to the medical records. And we are pointing towards the access right for patients and families under Missouri law. Any further delays from your esteemed hospital to delay access to the medical records is a breach of Missouri law. Any further delay in granting access to my brother's medical records makes us wonder if the hospital has medical information to hide. In the year of 2024, it should be no more complicated than sending me a username and a password to the MyChart app and getting access through the app. Why is there a delay? Does the hospital have clinical information to hide? Is there a hidden agenda? We would think there isn't an agenda, and therefore the hospital can just send all medical records through the MyChart app to make the healthcare of my brother and son transparent. We still haven't seen the reports of the brain, CT scans, MRI scans, blood results, medications, etc. Time is very critical for my brother as we speak. We are not happy with the care he has been receiving, especially as of late. His blood pressure is very concerning in the last few days and is only set around 73/42, which, by the way, is life-threatening. We understand that the doctors are telling us that blood pressure medications would possibly damage the kidneys worse than they are right now at the 15-point mark out of 60, which is at the tipping point of kidney failure. Our request to consider medication to be provided, such as dopamine or dobutamine, which is an inotrope to stabilize the pressure without further damaging his kidneys, has been ignored without even an explanation of why this would not be an option at this stage of urgency. Finally, one of the ICU doctors attending has entered the DNR code in my brother's charts against our will and consent, which means that they will deny my brother CPR or dialysis if his life depends on it, which is getting near this stage according to her conversation. Not to mention, she was very rude yesterday morning after just stepping in my brother's room. She explained that CPR can break his ribs, which we understand is a possibility. However, if CPR dialysis is not performed, his life depends on it, then he will surely die, which would be at that point a stage where he would not have any chance to survive and against the family's wishes. Now, I hear it all the time that, CPR is breaking someone's ribs, and it might. It might also save someone's life. Which one do you want? Which one do you want? Once again, you need to understand the narratives that intensive care teams create sometime, and you need to understand what you're up against, and you need to understand how to turn it all around, because you can turn it around with the right strategies, with the right advice, with the right gusto. So, the email still continues. If we are not considered power of attorney over my brother's life, then we should. Then why should we let ICU doctors who don't know my brother make life or death decisions? This is highly inappropriate. We do thereby strongly request that the DNR to be removed immediately, as we are seeking guardianship in a quick emergency matter to gain my brother's charts in order for us to even get a second opinion from a third party, which we are so much entitled to and deserve as family members. We are very concerned as we feel that the above statement in red letters has been something that the ICU doesn't feel is important whatsoever in this critical time. We are sure that your esteemed hospital is in a position to meet our expectations, and we're looking forward to a favorable response and access to the medical records by 5 p.m. today. So, and I can assure you that these letters do work, because hospital executive can't really ignore requests from patients and families. They can't really ignore that, right? So I haven't really seen that. Now, also, I think today was a really very informative session here, with looking at letters, with looking at statements from clients, with looking at the Cornell Law article about hospital discharges. I encourage you to watch it again. You can almost take those letters, watch the replay again. You can almost take those letters and implement for yourself if you have a situation like that. And I know there's a lot of patients out there and families out there who are having similar situations. So, we got to wrap this up in a minute. If you have another question, just type them into the chat pad. I'd be curious to know what you want to see next, so that I can really make those YouTube lives around what you want. Send me an email to support@intensivecarehotline.com. So, because we have helped hundreds and possibly thousands of clients over the years with intensive care hotline and also with intensive care at home. That's why we created a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email. And we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks, 21 videos that I have personally written and recorded. And all of that will help you to make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment always. Furthermore, I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. I handhold you through this once-in-a-lifetime situation that you can't afford to get wrong. When I talk to doctors and nurses directly, I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com with your questions. I offer a free 15-minute consultation that you can book on the website intensivecarehotline.com. If you click on the schedule my appointment there, you can book a free 15-minute consultation with me there. Or you can call me on one of the numbers on the top of our website. Now, with intensive care at home, and you'll find more information at intensivecareathome.com, we are currently operating all around Australia and all major capital cities, as well as in all regional and rural areas. We are an NDIS-approved service provider all around Australia. TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, DVA all around the country. Our clients have received funding through departments of health, public hospitals, private health funds, and so forth. We are also providing level 2 and level 3 NDIS support coordination. Our NDIS support coordinator, Amanda Richards, is here for you. We also providing TAC case management in Victoria, right? If you're at home already with intensive care, or if you're at home already on a ventilator, tracheostomy, BiPAP, CPAP, tracheostomy care, no ventilation, home TPN, and you're realizing that what you've got is not working, I encourage you to reach out to us at intensivecareathome.com. If you're an NDIS support coordinator watching this from another organization and you're wanting nursing care for your participants, or you need an NDIS nursing assessment, which we do with our critical care nurses with a legal nurse consulting background, I also encourage you to reach out to us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. We're also sending our intensive care nurses for emergency department bypass services, right? And we've done so for the Western Sydney Local Area Health District, their In Touch program. When we send ICU nurses or critical care nurses for an ED bypass job, we're saving $2,000 per admission. $2,000. So if this is your hospital, I encourage you to reach out to us. I'm sure you want to save $2,000 for an ED admission, let alone you want to have the empty bed, right? Also, we have jobs for ICU nurses in Sydney, Melbourne, Albury, Wodonga, Brisbane, Bendigo, Warragul. So have a look on our website or on Seek for our jobs that we've got currently going. So I really appreciate your time. Now, if you like my videos, give it a like, subscribe to my YouTube channel, share the video with your friends and families, and comment below what you want to see next so I can make these videos around what you want. Take care for now. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I'll see you again next week and during the week with my quick tip videos. Take care.